I'll just introduce the format. We're going to ask each of the panelists to say a few words about their particular contributions to the journal, and then we'll open it up for a few questions for each. So we'll start with Melinda Beeuwkes Buntin, who, as you heard, is the Director of the Office of Economic Analysis and Modeling at the Office of the National Coordinator for Health Information Technology.
Okay, thanks. I'll do it from my seat. We're a little tight up here. So I was privileged to be co-author on 2 articles that appeared in this issue, both of which had a first author who was an outstanding young researcher in this field. And I think it's a wonderful thing that so many young researchers are getting involved in the field of health IT. Those were Frederick Blavin and Emily Maxon. Both of the papers dealt with measurement issues related to the adoption of electronic health records, and that might sound a little dry, but under David Blumenthal's leadership, we've really focused within the office on measurement issues and on research for 2 main reasons. One is the old maxim that if you can't measure it, you can't improve it, and our goal is to improve EHR adoption. And the other is that policy should really be driven by facts and data, and we should really have an understanding of the effects of our policy levers as we exercise them. So the first paper looked at whether we could measure EHR adoption at a more granular, geographically specific level by using data, transactional data from the SureScripts network as opposed to data from a national survey. We found that the SureScripts data were a reasonable proxy and that they were growing better over time. And this is going to be extremely useful to us going forward because, as many of you know, our grantees operate, for example, our regional extension centers operate in 62 separate service areas across the country. And if we want to be able to track their progress, help them understand who's succeeding and who might have best practices, we need to understand how EHR adoption is progressing in each of those areas. And the same can be said for our state programs and our beacon programs. We also have the opportunity to understand whether SureScripts data can be indicators of other things, including who might be and should be registering for those meaningful use incentives. And of course, it's useful in and of itself for us to have access to these data because e-prescribing is one of the features of an electronic health record system that's been demonstrated to have real-world effects on patient safety and reduction of medical errors. The other paper looked at hospital adoption of electronic health records, and to sum it up, we found that there were many paths that hospitals were taking as they adopted electronic health records, and I found this both interesting and encouraging. It would be nice to say that there's one simple way for hospitals to progress, to start simple with this type of system and build on it, but in fact, I think the fact that there are many paths to success is consistent with the fact that there are many different types of hospitals out there, and that there'll be many different models that we can use to show hospitals how they can progress towards meaningful use. Then the final thing that I want to note is that we're really focused on tracking adoption and understanding the functions that hospitals and doctors are using within their EHRs so that we can understand ultimately how those affect their patient outcomes. And I think that that's the next forefront in research in this area. And given that the American Journal of Managed Care is focused on outcomes, I hope that's next year or the year after's issue.
Are there any questions? So I'd like to ask one, actually. So given the individualized nature of the adoption of EHRs, do you feel it's reasonable or realistic to set timelines for the implementation for innovation of health information technology?
Well, what we've done through the staging of meaningful use is realize that there are some functions which are a critical baseline to build on, and there are some functions which we expect to come to fruition in stage 2 and stage 3. So I think we are, in the way that the meaningful use is staged, inherently acknowledging that this is a pathway. One of the things that David likes to say is that you get people on an escalator moving up, and that's the way that EHR adoption will proceed. But I also think it was important that the meaningful use stage 1 legislation encapsulated what we thought was the core of what was needed to improve patient outcomes, because of course that's what we want to incent doctors and hospitals to do.
Terrific.